Informed consent. At what point is enough enough? A presentation by Matthew Snuffer. What is informed consent? At the simplest level, the term refers to the action of an autonomous, informed person agreeing to submit to medical treatment or experimentation. But what makes someone informed? How do we judge when someone has been given enough information to be considered informed? How can we expect someone to understand a complex diagnosis and procedures without having some sort of medical degree? Also, is there a place for therapeutic privilege when concerned with informed consent? During this presentation, we will examine some of these and other questions in an attempt to justify determining when someone has become well informed as it pertains to medical procedures in our healthcare system. Fundamentally, there are conditions that must be met before consent can be considered informed. Typically, they maintain that an informed consent exists if and only if the patient is competent to decide, she gets adequate disclosure of information, she understands the information, she decides about the treatment voluntarily, and she consents to the treatment. It is also important to note that a competent patient reserves the right to refuse any treatment they wish. Therefore, it is not enough to simply provide adequate information, but the provider also needs to ensure that such information is understood by the patient as well. Informed consent is justified when it appeals to the ethical principles of autonomy and beneficence. Autonomy refers to a person's rational capacity for self-governance or self-determination. It's the ability to direct one's own life and choose for oneself. Autonomy and informed consent are interlinked, as you cannot comply with one without complying with the other. It is not possible to fully respect a patient's autonomy without also respecting a patient's right to privacy and right to participate in the decision-making process regarding treatment and care, including giving informed consent for that treatment and care. Beneficence says that we should do good to others and enjoins us to advance the welfare of others and prevent or remove harm to them. The ethical doctrine of informed consent says that disclosure is adequate if it allows patients to weigh intelligently the risks and benefits of available choices. In 1986, Faden and Voikamp devised 3 criteria for informed consent, which consisted of: a person must consent based on an understanding of the information, consent must not be controlled by influences that would engineer the outcome, and consent must be the intentional giving of permission for an intervention. Despite many difficulties, courts and legislatures have made mandates on several pieces of important information that must be disclosed. These disclosures include the nature of the procedure, the risk of the procedure, the alternatives to the proposed procedure, and the expected benefits of the proposed treatment. The nurse's role in the informed consent process is to witness the client's signature on the informed consent form and to ensure that the provider has obtained the informed consent responsibly. That is to say that not only have the above-mentioned mandates been met, but that the patient also understands the information that was given. So far, we have discussed situations and information that are necessary before informed consent can be considered informed. What about a situation where it may be necessary to withhold information? Therapeutic privilege is the withholding of relevant information from a patient when the physician believes disclosure would likely do harm. If a physician deems the patient too distraught, depressed, or so weak that the disclosure of adequate information may make their situation or condition worse by them knowing, some may argue that it is proper not to disclose the information in such a situation. This is called therapeutic privilege. If we were to look at applying some of the major theories, we might find that utilitarianism dictates that we judge actions involved in informed consent by the overall good that they will produce for everyone considered. A ruled utilitarian might conclude that the best overall consequences would be achieved if physicians consistently followed a rule requiring informed consent. However, a strict Kantian would argue that informed consent is an absolute requirement, and that because lying to them by withholding relevant information would be treating them merely as a means, therefore therapeutic privilege would never be permissible. Finally, Rawls' contract theory seems to support the doctrine of informed consent, as treating someone without informed authorization would be a violation of their basic liberties. The responsibility for informed consent lies with the provider, the patient, and the nurse. For it is necessary for the provider to obtain informed consent by means that have been outlined herein. The patient gives the consent, and the nurse to witness the informed consent. The American Nurses Association Code of Ethics for Nurses, Provision 2, states, "The nurse's primary commitment is to the patient, whether an individual, family, group, community, or population. This provision dictates that the patient is our priority, and that we should keep the patient's best interest in mind rather than what is best or convenient for the provider." Provision 3 states, "The nurse promotes, advocates for, and protects the rights, health, and safety of the patient. By this, it is imperative that we advocate for the patient if informed consent is not being met by the criterions herein set forth. By this principle, respect for autonomy, respect for persons, and respect for self-determination are maintained as well." What if the mandates are not met? If the mandates were not met for informed consent, for instance, if the patient did not understand what had been instructed by the provider, and the nurse stood by and did not advocate for the patient, the decision to stand by and do nothing may have dire consequences. At the very least, it would injure the nurse-patient relationship and erode that trust. It may also result in legal action being taken towards the nurse, where they might lose their job, lose their license to function as a nurse, or it could result in the patient losing his or her life, although there are some exceptions to informed consent. Disclosure is often dispensed with in emergencies when stopping to obtain consent could seriously harm the patient, or in situations of therapeutic privilege. Although critics worry that too many physicians use therapeutic privilege when they should in fact tell patients the facts, and that the overuse of it could undo informed consent. Aside from opting not to get informed consent in an emergency, I believe that therapeutic privilege could in some cases cause more harm than good. We have examined several aspects of informed consent from a nursing point of view. The consent of an informed, competent, understanding patient cannot be legitimate unless it is given voluntarily, that is, freely, and without undue pressure from others. I conclude by saying that besides in an emergent situation where it may not be possible, consent should always be informed, and we should educate ourselves on the material as well in order to ensure that the information given by the provider is enough to be considered adequate. So far, we nurses appear to be doing a fairly good job at making sure that this happens. Our communication skills affect the perception of patients regardless of age, education level, and past experiences. A recent study found that nearly 72% of the participants of that study had a positive perception regarding informed consent in nursing care practices. If we apply the major theories of ethics properly, We may find that only in an extreme situation should therapeutic privilege be permitted, and even then it is questionable. Finally, our patients have rights, and we should respect those rights, at the very core of which is the patient's right to accept, refuse, or request modification of a treatment or care plan. It is up to not only the provider but the nurse as well to see that the patient makes these decisions based on informed facts and not coercion.